Good morning. I'm Kofi Techi Asamoah, and I'll be presenting today's ECG conference. We are going to have a series of ECGs all belonging to the same patient. I think we have a total of 5 or 6 ECGs to look at, so go right ahead. This is the first one.
We have discussed?
Yes.
Okay.
But I think Wasim knows this. Wasim knows this case as well as I do, so I think he should abstain for now because he knows the case. Yes, we were in the case together, so he knows.
For now, we have a 5-second rule. You keep quiet 5 seconds. Next people. Okay, fine.
First of all, the heart rate is about 70 to 80, and the axis is on read 1 we can see it is positive, and on read AVF it is positive, so the axis is good, and on the base the morphology of P wave is good, so we can find that there is no arterial enlargement, and based on the QRS morphology, I think that only I can find the one kind of QRS morphology. So I think it seems like it is normal.
Okay. 2 fellows interpret as normal. So do we have to discuss more?
So here now, is a little bit shorter side than normal, right? If you say the heart rate is 70 or so, or even maybe 50, sometimes more evident, here is a little bit shorter than you like to see. Okay. So is in other words, the PR segment should be seen proportional to the rate. The faster the rate here, faster it's slower, it's longer. Obviously, patient have underlying enhanced AV nodal conduction, for example, what we know that used to call short AV nodal, your PR can be shorter. Okay. But other than that, what we have discussed. Okay. Okay.
With these blue markers, does anyone have anything to add based on the blue markers on the screen now?
You marked?
I've highlighted one. Huh? In V1, I put 2 blue markers over there.
We talk of PO axis. Here is a very low amplitude.
Okay, I'll move to the next.
I think there are people who has clean mind can see something, but I cannot see anything.
Okay. This is another ECG patient.
Oh, yes, that's full PA.
Very little bit too.
All those are PA, you think?
Yes.
So, and the we too, I think it has a big U wave, but no other P wave.
If so, what did you do to this patient?
This is another ECG, same patient, 2026. So the same pattern we saw in 2022, 2024, 2026.
So if you look at the P wave axis, okay, if you're discussing AVL, P wave is flat or almost negative. Okay. And lead 1, very small, tiny positive. Okay. V1 precordial transition of P wave is abnormal. That's if you're arguing that. D3 until the ear flat. That's not normal, right? And all the precordial P wave is very flat.
But I don't agree with Kofi's hypothesis because the sinus rhythm coming from the right upper side. So AVR lead reflects most precisely the sinus node activation. If you look at the AVR, I think a negative P wave coming from the much later than your mouth. What do you think?
Is wave, like the AVR wave is the baseline of wavy. I don't know what we can help from that.
Can I see the previous one?
Previous one, yeah.
Yeah.
This one you can see better.
Very clean negative P wave in AVR.
Do you think there's a U wave in this or
Yeah, there's U wave.
There's a wave in the
precordial.
precordial.
Yeah.
V2, V3, and then also V4, V5, V6. But it's not a gigantic U wave. U wave is a little longer than normal, but
and then in the next ECG?
yeah. So
Again,
yeah.
you think it's a U wave or
There's a still U wave there.
Too delayed.
or is it used to like U?
Lead 2.
Yeah.
Lead 2.
Yeah.
Lead 2, you have a U wave artifact variation here. Take a look. So first complex, U wave is flat.
Mm.
Unless you're talking about you have alternance here. Okay? Biphasic. Next one, flat. Next one, positive. Okay? And the next one, there's no U wave. So wave baseline is wavy. Okay?
Mm.
And then if you look at the next one, U wave positive. That's a T. U is right behind. Next one, you have a slightly flat. Then positive. Baseline wavy. So I'm not sure you can conclude U wave is the alternate here because of baseline to wavy. For you to see U wave very clear, you better get a good tracing baseline stable. Otherwise, you can interpret. I can see that the U wave fluctuation there, but there is alternance. I don't think it is. Okay,
It's the baseline is
Yeah.
drifting,
that's a problem.
but the copy is smiling very
So the patients actually in 2022
okay.
had a pacemaker put in for sinus node dysfunction. And so this is an ECG, immediate post pacemaker implantation.
Okay, is a bipolar lead program the bipolar?
Yeah.
You know,
I think so.
not a unipolar,
No, but
bipolar.
Yeah.
You see that big sharp the energy output is programmed very high, or why there's so much striking spike? Most of bipolar these days, almost you don't see pacing spike because pacing configuration. It used to be integrated bipolar, then you have a longer pacing interval, then you can see spike. But these days, the lead design, many other things, very close pacing. You don't normally see that big sharp spike unless your output is very high. Okay? Unless patient threshold was very high and then the programming high output. Okay?
And the latency also.
P wave interval is quite long.
yes.
Into the
Latency.
into capture with the first
That's
period.
why you marked it in the
Yeah.
previous see that. Right?
But it's not uncommon to see pacing marker to the capture the egg manifested P wave to the ECG. That's the reason we talk all the time. If you guys are going to program AV delay, you better do it under the 12 ECG, not by pacemaker programmer. Pacemaker going to show you I'm pacing like the Q, P, and R, and so on. That does not reflect the patient actual electric activities. Okay. Similarly, LV pacing. Very careful. Some people have an exit block. Your pacing spike is over here. Actually, evoke QRS complex way late. Then you have to add on that delay into your BIB programming. Okay? So many times my fellows don't do 12 ECG after they're changing the programming in patient, they set them home. And suddenly patient come back with more heart failure. And then they tells me, I programmed it right. So I tell them get EKG. You can see certainly that patient had an exit block. Spike, let it spike here, but local activation is about 80 millisecond delay. Then if you have a delay program, 80 milliseconds, you're hitting the same place. That doesn't make any better. So it is important concept when you follow the pacemaker, do that. Especially also when you implanting LV lead, left side, let's say cardiac vein, you better get a real EP tracing, not just based on the program rep guy tell, oh, it's a capture, blah, blah. That doesn't make any sense to us, okay? Yeah, it's a very important concept. It's not uncommon to have this slight delay of 100 millisecond or 80 milliseconds. Many patients with 6-sided syndrome will have a bad scar tissue. Even the threshold is good, you will have this delay. So you need to keep looking into that. So my fellows the other day presenting Bachman bundle pacing. Pacing spike was here, stimulus either QRSL or BP was over here. I said, how do you know that it's Bachman bundle pacing if such a delay? You can. Okay. So this is a very important concept. Pacing exit block. Pacing Wenky block. Pacing can have Wenky block too. Okay. So don't forget that. So you did because you're like automatic rhythm. You can have an exit block, Mobius 2, Wenky block, all this can happen. Okay, sorry, interrupted. Go ahead.
This ECG was done last month,
Okay.
and again, you see the same phenomenon. Looking at V1.
Okay.
The after the pacing spike, we see what's supposed to be the P wave, and any comment on the P wave over there? Because when you pace, you expect a single regular P wave.
Okay.
But over here, we have something much broader.
Okay. Interconduction delay, interconduction delay. Oh, your pacing site has a exit block with a delay propagation wavefront. Maybe your totally DCG. If you look at the lead 1, lead 2, and 3. Look at where the P wave is spike carefully. They're same or different, a little bit different. So there's also a regional variation of interconduction. Okay. So we used to calculate all those to try to figure out where the best pace to pace, but that's too much craziness. Okay. Like we had a guy named Charles Swadlow who did the pacing craziness. He did all that stuff, so we didn't care too much about it. But it is important concept to know that there's also regional delay. You're talking non-normal heart, scarred heart. So you pace here, you conduct until certain points of normal, and then blocks, and the conducting delay occur later. That's why sometimes you see pacemaker-induced arrhythmia. Okay, you implant the pacemaker, suddenly you start having tachycardia. Then you start figuring out why it happened. Then your answer is going to be automatic trigger, or this is a delay conduction re-entry. It's possible. Okay, sorry. You're the presenting.
Any other comments? I should go ahead.
Okay.
Let's think about the reason for this abnormal is a behavior. So is this patient has some cardiomyopathy or atrial myopathy or any other underlying disease?
Well, this patient has had atrial fibrillation and flutter, for which PVI and CTI ablation have been done.
So it's PVI and CTI.
Yes, just
which year?
2023.
2023.
Yes. So that's after the pacemaker was implanted.
So the P wave amplitude is progressively reduced.
Yeah.
Right?
Yes. Looking at the
In other
previous
words, there's some
ones.
progressive.
So second consideration, the interconduction delay is gigantic this patient.
Yeah.
If you
Capture delay. Actually, capture delay is
not just capture delay, also interconduction is long. Okay. If you look at the lead 2,
how do you determine the interconduction delay?
because your P wave M is separate out already.
Duration.
Yeah. Okay. So long duration, but also vector here. If you look at it carefully, from there you cannot see very well. Capture P wave once a year. Negative, positive, lead 2. So vector of right atrium to down, left atrium up. That means a long turning around this thing. So you have a delay of significant interconduction delay. So this kind of patient, you ablate more, they become right atrial dissociation. Sometimes we see this.
So for me, it is real the P wave or not.
You do real clear.
Really?
Yes.
How do you know?
How do you know? You can look at the EGM. Okay. So you should know in interconduction delay during the EP study. That's why we need to put a catheter in the right place. That's why atrial fibrillation ablation, no matter what.
Where did you hook up the atrial lead?
Right atrial appendage.
Just as
The conventional
point.
But if you create, for example, septal line, or you create so on, your left right atrial connections, remember only 3: Bachman bundle, septum, coronary sinus. You cross septal line, Bachman bundle sever, septal line sever, only thing left is the coronary sinus. Then you decide to do over flutter ablation. Pretty soon you see, left to right atrium dissociated. We experienced the early days. I made a lot of mess too. So I ended up doing biatrial pacemaker with the patients. Because if you look at the echo, Doppler, right atrium, left atrium contraction complete separate. The feeling defect in the low functions and so on is most important. So we created a lot of mess before. So I think this is another problem issue that we face.
Is the owner of this ECG mine?
No, we don't know that. Okay, that's confidential. We cannot say that. Okay, go ahead.
Okay, so this is a 68-year-old female who managed for hyperepidemic ejection fraction, EF of 60 to 69%. Right? She has biatrial enlargement. The right is larger than the left. And she had a DDDR pacemaker implanted in 2022 on account of sinus node dysfunction. And had PVI and CTI ablation in 2023 for paroxysmal AF and flutter. She has no structural heart disease and had been maintained on propafenone and bisoprolol, but was having some dyspneic episodes and was then continued on nebivolol only. She was brought back to the EP lab because of an atrial flutter. I didn't add that ECG though, but she came for the atrial flutter, so we sent her to the lab. Before that, this is the X-ray showing the lead positioning, and we can see that things are where they are expected to be. And this is just an echo showing the atrial signs, right atrium being larger than left atrium. So during the ablation, after the ablation, we decided to assess the interatrial conduction. And here we have the spike. So this was pacing from the atrial lead of the pacemaker. And we see that from stem to high RA, the earliest signal was 33 milliseconds after stem. And we see that in the rest of the RA, we barely see activation. Then from the high RA, so the decapolar factor was pushed anterior all the way to the left atrial appendage area, which is approximately where the Bachmann's bundle was set. So from high RA across the Bachmann's bundle to the left atrial appendage was 240 milliseconds. So that shows us that the conduction from the right to the left was prolonged. Just to, as an overview here, we have the interatrial conduction system. So from SA node, Bachmann's bundle conducts to the left atrial appendage and also sends a branch down the interventricular septum into the AV node. And then we have the middle interatrial tract or internodal tract, which also conducts impulses posterior to the SVC and then down the interventricular septum, sending a branch through the foramen ovale into the left, through the fossa ovalis into the left atrium. Then we have the posterior fibers, which go down along the crista terminalis, around the tricuspid annulus, the area of the slow pathway, and then connects through the coronary sinus musculature across to the base of the left atrial appendage, and then goes into the AV node. So this is how the conduction between the atria is. Now we did an activation map, and here we can see that activation begins here where the pacemaker is, but we see that there's where the atrial lead is, but there's pretty much no other conduction within the majority of the body of the right atrium. Then it doesn't conduct across the roof of the atrium along the Bachmann's bundle as expected, but rather it comes down towards the septum and then across through the fossa ovalis area and then also the coronary sinus area. So the ECG findings essentially show the result of the prolonged interatrial conduction, where we have the right atrium being stimulated a while after the pacemaker spike, and then it also takes a long time for the left atrium to also be stimulated. The first ECG in 2022 It's a bit difficult to see. Looking up close, this area looks a bit hazy, but it's not a clear, distinct wave. Over here, it's a bit more prominent. Well, the activation here, this is sinus rhythm. We see a P deflection here and another one here. So this may have probably been one of the first signs of this interatrial conduction effect. We see it again here in the 2026 ECG. Here it's actually a bit more prominent. And then once the pacemaker was put in, it stood out much more. So this was in 2022 and then in 2026. So this is just showing.
Can you show the echo for me? Your echo. Okay. What do you see here?
The right atrium is larger than, so the left.
No, I'm asking atrial septum. Is that normal?
Interventricular? Or
Atrial. I don't know. Again, atrial septum. Look at the 3D map now, too. This is going to be education for you guys. You see, you play the propagation map there. You show the slide to the interatrial space. That's normal? That big? Not normal. Thick. What does that mean? This patient has a probably lipomal septum. People have a lipomal septum, they don't have vacuum bundle. Okay? Very weak connection. Right? Lipomal septum separate. Watterson groove. During the formation, your vacuum bundle is going to be very thin or sometimes disconnect completely. Okay? That is another contributing factor of a sick sinus syndrome in this patient. Very common. Okay, so be careful. So when you guys do transeptal, you look at say, wow, I got thick vacuum bundle, all that. When you look at the agent very close. When you look at the vacuum kind of slow, infiltration of fat tissue, lipomal septum, then difficult to transeptal. That's something that you need to notice. We find that once in a while this kind of patient, they're the high risk for AV mechanical left AV right dissociation during the ablation.
How the size of atrium is progressively increased?
Yeah, I think so. Yeah.
So definitely this patient has atriomyopathy, progressive atriomyopathy.
And I'm wondering whether the patient is restricted cardiomyopathy. Because they'll be very small.
He will get AV block in the future because the crista terminalis pathway is blocked by CT ablation. Vacuum bundle conduction is very poor. Only the major conduction is through the septum. But if I don't know how much the scar area in the septum, if it progresses, probably he will get VPC because of AV node conduction. But still, I have a lot of doubt your hypothesis because I think the 2024 ECG, yeah, it's plausible, but the before,
yeah,
no, before, yeah,
This is
I think it's your guess because the ECG P wave is generated by myocardial activation, but this patient is right atrium almost atrial standstill. So the right atrial activation cannot show up in the ECG, and generally the V1 P wave initially positive by RA activation, and the negative P wave force is LA activation, right? So if you look at this, the negative wave is much later than your marker. So I don't know, nobody knows the answer, but I would like to against your hypothesis.
So, but a 12 EKG this patient is have a baseline trend of cardiomyopathy. Look at the recorded voltages versus limbally the low voltage. And if you look at the echo, patient has a dominant biatrial enlargement, preserve the ejection fraction. So you start wondering what's a basic true mechanism cardiomyopathy, probably restricted cardiomyopathy this patient. She's a female. So you need to look at that first, because that is probably what helps more patients than pacemaker all this business. So you need to deal with it. If there's a restriction, you got to deal with that. That's a typical echo you see. Big biatrial enlargement, normal, small ventricle. Look at the echo. There's a hyper echogenicity in the all endocardium. Go take a look. Echo. See you again. Go. Okay. That's a typical pattern that we see. You show echo and then we'll see better. Go to echo window.
Yeah,
then
from
you show-
this one, 2024, it's highly suspicious, but I cannot agree with it.
Well, it's, well, atrial myopathy show question is that, what would be the, you just look at the echo.
But sometimes it also depends on the echocardiographer, the
Understood.
position of the
Yes,
probe.
but it's, too much discrepancy between atrium and ventricle.
Dr. Zhang, how do you think? He's a,
He's an echo guy.
he's some subspecialist. I'm sorry, imaging.
First of all, compared to LV and RV, biarterial enlargement we can find, and in aspect of the septum, as we can find that interarterial septum and interventricular septum is so thick, and I cannot find any valvular movement, so I cannot say anything about. I cannot say something about that, but yes.
Okay, so it's time
Right.
to wrap up because we have international conference from 9 o'clock, and thank you very much. Okay.
Yeah.
Oh, Dr. Tong, so what is that? Madance.
Thank you in my language.
Oh,
Medate. Okay, medate copy.
so when you guys do the pacemaker, maze, post-maze patients, you're gonna have a lot of trouble because of this. Just remember, okay? That's the most challenging cases. Post-maze, Cox maze, I'm talking, not the mini maze, full Cox maze. The surgeon chops out all the section, so you better find the measurement.
So I would like to present a case of a 40-year-old man with underlying generalized anxiety disorder. He presented to the emergency department for palpitations, and this is the 12-lead ECG that was done at the presenting center. Apologies for the quality of the ECG. This is the only ECG that we obtained from the referring center. So as you can see, it's a narrow QRS tachycardia with possibly a long RP from here. And then at the presenting center, they given adenosine 6 milligram, then it reverted into a sort of an unremarkable sinus rhythm ECG from here. Okay. So for further workup, patient denied any illicit drug use. Laboratory investigation showed no abnormalities. Echo was a structurally normal heart. So we proceeded with electrophysiological study with a 4-wire study. So this is the baseline study. The basically unremarkable age is about 102, HV interval is 39. Okay, during the manipulation of the CS catheter, patient suddenly developed tachycardia. So as you can see, it's a concentric atrial activation, and then the VA is about 104. The tachycardia cycle length is about 280. At this time, our differential was autodromic AVRT, ATEC, or a typical AVNRT. So we did some PVC on his refractory maneuvers. The first one actually terminated the SVT, but ended with a retrograde A. So basically from this maneuver, we ruled out atrial tachycardia. And then the second attempt, it actually advances slightly, the next A, from 350 to 330. But bear in mind, the cycling was a bit wobbly. Like from 350, it became 380, 350, 330. And then sort of like a jump here, about 330 to 410, and then 350. So the cycle length is a bit wobbly. So thinking about the typical AVRT, sort of like basically confound the diagnosis. So we did another PVC on his refractory. At the same time, our differential for the wobbling cycle length either could be a functional bundle branch block, or is it a multiple accessory pathway with but there's no VA interval changes. The VA remain the same, about 100 and 104. Or it could be a dual AV nodal physiology, like alternating slow, fast pathway. Or it could be because of patient own autonomic shifts. Because patient is a psychiatric patient with generalized anxiety disorder, this patient might have some autonomic shift in terms of the AV node. Okay, so we measured the AH after the PVC on his. Actually, it's from 186 suddenly jump to 300. So possibly it jumped into the slow pathway at the end of at the PVC on his maneuver. Okay, the third attempt on PVC on his refractory, also the same outcome, advances from 360 to 300, but there's like a jump after that from 300 to 470. And this is the fourth attempt on PVC on his, also the same, 380, and then it advances to 280, and then it also jumped to 500 after that. So we did entrainment. So basically it's a VAHV response. The return cycle length is actually long, about 166, but the SA minus VA is about 52. So there's a discrepant findings. So we corrected the discrepant finding by minusing with using the formula of the corrected post-spacing interval minus tachycardia cycle length, which actually shows that it was actually a short return cycle, about 66, because the AH after the maneuver was 350 milliseconds, and then 56 milliseconds, and we minus with the baseline, so it's actually about 66 milliseconds only. So this probably confirmed that this patient has actually dual AV node physiology and possible autodromic AVRT. So we mapped with the HD grade during the procedure. The earliest breakout was found near the CS os, but there's no fusion of the signal. So we cannot really get a few signal from all of the mapping. This is the activation propagation video. Okay, earliest breakout came near the CS os. So we decided to map the left atrium because of this, because we cannot really get a few signal, but no early signal from the left atrial mapping. And after that, we map into the CS, and the earliest signal was actually near the ostium of the middle cardiac vein, but there's no few signal over here. So this is a propagation video. So it comes near to the MCV ostium at this point, but there's no few signal. So we ablated near the area using a tactic cath ablation catheter. So after the ablation, tachycardia was not inducible, and then we did adenosine challenge, which showed VAD at S1 of 500 milliseconds. So our conclusion at this point is it's actually a pathway, accessory pathway, in the probably a epicardial component at the MCV os. At the same time, this patient also probably have dual AV node physiology, causing the cycle length to be a bit wobbly. So I think this is the main point of discussion. What is the differential for a wobbling variable tachycardia cycle length for an SVT, and also a typical pathway location that is located near the MCV. Although we cannot really get a few signal, but after the ablation at this area, there's no more tachycardia that's inducible. So this is a lesion that we created. All right, so basically that's it.
Can I ask a question? Do you have your cine position with your catheters? Where did you deploy
the CS venogram? Unfortunately, the images were not safe. So, but the positions are quite the standard position, as you can see from the 3D map here.
Where's your RV catheter?
The RV catheter, it's in the standard position. I'm not sure why it's not here in the map.
So can you show me the your V entrainment tracing?
All right. Yeah, it's here.
So you're showing that the lead, first lead is what? Is the one, you're displaying the lead, 3 leads that you display 12 lead. Can you tell me what are those leads are? Not written under your...
Okay, this is a HRA.
No,
catheter.
I'm surface ECG.
Oh, surface
12 lead
ECG. Okay. So basically, there's we entrain from the RV apex. So
RV
this
apex.
is yes, we entrain from the RV apex. So you can see this is a pace QRS from the RV apex. So before that, we didn't have I didn't show here the EGM, because I couldn't really show the fusion, the dynamic fusion changes lah from the beginning of the treatment.
Your lead in the top 12 lead cities, that's lead one?
Yes, there is lead 1, lead
Lead 1.
2, and
then your lead
V1.
one is biphasing.
Yeah.
IV capture. Right?
Yes.
Pacing, IV pacing, lead one is biphasing.
Mm-hmm.
If it was apical, would be unlikely.
So it would be septalish.
The septal, I think.
Yeah. Yep. Mm-hmm.
That also shown by the fact that your IV catheter on the bottom, I assume the green color, is that correct?
Yes.
That is earlier than your other V, so I think it's a septum pacing. You have to discuss if you pace the posterior basal septum of the RV, would you think I have the same problem?
Posterior basal.
Actually, pathway, or just thinking.
Probably it would not affect much because still in the circuit of the AVRT.
Yeah, I think it's trouble that we are many times doing SBT. Pacing size matters quite a bit. Okay. Yeah, I think it is a classical teaching. Many elder professors used to teach us. So if you doing SBT, let's say that your left lateral pathway, sometimes we pass the RB outflow tract, not the RB septum or apex. If you're thinking that the patient has posterior septal pathway or posterior pathway, you may want to pace a posterior basal area, which is a closed axillary pathway, favoring for the pathway conduction, not the normal conduction of the right bundle, so on AV node. So I think that may be also possibly responsible for your tracing. Okay, that's one of the possibilities.
Okay.
Yeah.
All right.
Second point is that if you look at you have the beautiful his bundle potential there, clearly septal. But look at the conduction discrepancy between CS proximal and then your his bundle, his A. Now during the tachycardia.
Okay.
You can see CS pretty much eccentricity, right?
Yes.
If you have a slow AVNRT, your CS wouldn't be that sharp eccentricity because the CS proximal 7, 8, so on should be almost kind of a curved shape. And also not much different. So as coronary size activation, if your CS got the proper place, just looking at the CS activation, you can pretty much start thinking, this got to be pathway, not the AVNRT, okay? That I think most of the time we miss it because when you see a delta between CS to the HIS-A, proximal CS to the HIS-A is too wide, okay? Usually difference between the proximal CS, HIS-A is less than 10 milliseconds. AVNRT cases. Okay? Because slow pathway inputs are very diffuse. It's not as specific like a pathway. So that's something that you need to start thinking about those. Okay? But tracings are very clear. It's beautiful. Okay?
Okay. So what do you think about the wobbling cycle length? Do you agree with me that it's a slow pathway, just the AV dual node physiology in this case?
Yeah, I think so. But then, if you look at the returning bit, okay? After the slow, if you're thinking that the returning bit is a slow pathway, anterior conduction went down to the slow, I assume that's what you're referring to, right?
Yes.
And then you're coming back to the axillary pathway. So you would not be able to see, but if you notice the previous tracing, HV interval, you measured, I think there was a HH interval you measured, right? Yeah, bring the V extra. Yeah, go to the V extra with HV intervals. See, you had a single extra right there. So you have a his bundle HH. Did the HH change post pacing HV interval?
Yeah, it changes.
Slightly longer. HV, not AH.
Oh, HV. HV.
Just before that,
HV
right after pacing. Yeah, next HV. Yeah, there. Is it longer or shorter? No change.
No change. Yep.
Right.
Yep.
So that probably almost against the nodoventricular tachymetric axillary pathway. That's one potential issue could be here. Second would be that your impulse propagation during the V extra returning. Do you think it's the same when you do V extra? His proximal timing with the CS proximal timing. I think it didn't change. So it went through the pathway.
Yeah.
So,
Yep.
yes. So
Mhm.
most likely the slow pathway conduction. Okay,
Oh,
you're ruling
okay.
a lot of possibilities.
Mhm.
If you had a fusion, then your retrograde activation would change EGM, but it doesn't change. So
Okay. Have you encountered any pathway that you cannot really get the fusion and you just ablate at the earliest atrial activation? Like in this case, we couldn't really find the fusion. Probably it's epicardial. That's why we cannot really find the fusion. But after ablation, it's actually terminated the SBTA. So what do you
Sure.
think about this? Mhm.
Well, most of us try to record as much as possible extrahepatic potential.
Mhm.
But the posteroceptal region, as you know, anatomically, very much a complex area, and the coronary sinus musculature, so on. So you just found the earliest A there. That's what you
Mhm.
did. You did
Yes.
not look for hepatic potential. So question
Mhm.
we wonder if you look at the, a little bit more to the left side septum, right side septum, so on, I think it would be more clear because you're dealing with the posteroceptal pathway, possibly MCV origin.
Mhm.
And some of those pathway potential can be found in not just only that area because their branches are quite big. So our approach to do, at least my personal approach is that when I see posteroceptal pathway, first thing we do coronary sinus venogram to look at the coronary sinus anomaly. And then we map the coronary sinus and we map the right posteroceptum, left posteroceptum. When we put a map together, you did the left side of the mapping looks like there in your
Yeah.
3D
Yes.
map, right?
Yes.
So I think once you rule that out, then you can say that you couldn't find the extrahepatic potential. Some patients, some investigators even go to the LV posteroceptum to find the ventricular insertion of hepatic potential, if you really want to look for. But you're basically looking for earliest A activation in 3D mapping. I think that help you. But in country that you don't have a 3D mapping, maybe that's what you're obligated to do it. To do all mapping first, then you decide where to ablate. Okay? Yeah. You guys have a good 3D mapping system, then you can figure out what it is. But I think I would have done CS angiogram first, look at that area a little more carefully. May help you to map the hepatic potential. Okay?
Yeah. Yes. Yes. Agree.
May I ask one? How early was the earliest A as compared to the CS proximal?
I mean, you're looking at the only right there. If you look at during the PBC, mostly A, I think. There's no V.
Yeah.
How early was it? How early?
I don't know how early it could be. It's just you don't have a hepatic potential.
Yeah.
Because usually, if you have a VA conduction time is a little bit longer patients, you're going to have hepatic potential close to V rather than A. Okay? So then they are looking at the AV there, VA right there. First is I think complex is a V, and the second big one is the A ablation. That's what I'm assuming here. That's what I see. But I don't see any potential between. So
Yeah.
I think they ablate the basic A site. That's what they did.
Okay. Basically,
So,
any more questions?
something that may I suggest you that during the tachycardia, really you want to find the hepatic potential. In early days when we did not have a 3D mapping, we also used to pace from the LB posteroceptum. Okay, that changes up activation vector. Then you can mask on hidden hepatic potential to show up right after the V. That also possible. Okay, but these days we don't do that anymore because we got very fine density, high density mapping, so on. You can ablate it. But some posteroceptal pathways, you cannot find the extrahepatic potential right at the atrial insertion or mid. So some of them end up ablating ventricle insertion. We've done that too. Very difficult cases. So yeah, that's something that you want to keep that in mind. Okay. Yeah.
Okay. All right.
We have panelists today.
Yeah, Dr. Pagma.
Hi, Padma.
Good morning, professors. My name is Bagumdolum, and today I'm joining from Mongolia. And thank you so much, Dr. Achik. And that was an excellent, interesting, and educational case. And I really enjoyed your case. And I have a few questions because
Yeah.
I'm new electrophysiologist, so I don't understand something, and I have to clarify.
Yeah.
And what do you think think was the underlying electrophysiological mechanism responsible for the wobbling phenomenon? And which finding convinced you that this was EVRT rather than another form of SVT?
Okay. So our first differential because of the long VA tachycardia was either it's autodemic AVRT or is it an ATAC or typical AVNRT. But we did some maneuvers. As you can see, the PVC on his, the first one actually terminates the SVT with PVC on his. So basically rule out AT because it ends with an A. And then left with the two differentials, AVRT and also AVNRT. So the second PVC on his show that there's some advancement for the next A after the PVC on his. This one mostly in favor of the AVRT. But at the same time, looking at the cycle length, it's actually wobbling. But as you can see here, from the at the end, the next A after the PVC on his was actually more prolonged, like a jump here. So you can see the his from here has actually entered greatly to the slow pathway. Reached about 300 here from the baseline of 180. So for me, the VA remains the same, just that the AH differs for this patient. The AH component actually makes the cycle length variable for this patient. So from this finding, I deduce that it's actually an AVRT, but with a dual node epiphysiology with jump phenomenon lah in this case.
Thank you.
Mhm.
Measure the HV interval during the pacing and post-pacing HV interval. What was the difference?
From here, as you can see from this is you can really see the his from here, right? But after the post-pacing interval, you can see the separation of the his signal over here. So this is the one that basically from the jump, okay, the his that goes into the slow pathway left on the entry. But from the pacing, the his I cannot really see the signal. Probably it's fused with the either the QRS. Mm-hmm.
Thank you. Those are
Mm-hmm.
my comments and questions I have
Yeah.
regarding this case. Thank you.
Dr. Apali, this is Hinampal in Korea. Thank you very much for sharing the very interesting case. And we had an answer, the reason for the wobbling phenomenon. But
Mm-hmm.
the Dr. Washim, Kashmir, India, asked a question, how is the VA interval during tachycardia and after V-pacing? Am I right? Your question was that?
The V interval.
Yes.
Sorry, can see the question back? Okay.
VA interval during pacing and during tachycardia, how differs it?
Okay, so this is basically the VOD. But the V interval remains the same during tachycardia. It's about 100 millisecond. Or 100, and then for the difference is just the basically the AV lah, AH. So the on pacing on the V slightly prolonged, probably about 156 from here V to A. It's about 156, but from the tachycardia it's about 104.
Is that good answer to you?
Also, the place where they ablated, how early was that A as compared to the earliest A on CSA?
About 22 milliseconds
20.
from the measurements. 22 or 25 from what I remember. Yep. Yeah.
But as you know, posteroseptal pathways, they have a tendency of a many branch because of anatomic complexity of that area. So often, if you don't want to ablate multiple area, you better find the integral insertion pathway.
Yes,
not the
that's my
attenuation.
point.
Okay.
Mhm.
Therefore, your pathway potential should be much earlier than that. And they usually embedded sometimes often very end of a QRS come locally. Okay. To see that best is the unipolar signal. So unipolar signal we'll see just not regular QRS, but regular RA, but it's a notching. And that is very typical characteristic. So it is something that you may want to think about doing next time, such a complex case. Display unipolar electrode 1 and 2. Take a look at the vector activation of that notching. Distal should be earlier than proximal. Not the R, not the anti-QRS, but that notching I'm talking. I will hopefully show you one day what I'm talking. It's very, very characteristic. So we do that in third world country where we don't have a 3D. We use a bipolar unipolar together. And that has been quite helpful for most of my fellows.
Is it possible that the pathway was just a bystander?
I think so.
And we ablated it, that area, it took care of the slow pathway, and that's why the.
No, I think slow pathway, you probably, it wouldn't be that area because it looks like you ablate an MCV os. Let's look at the pit map. So I think it's slow pathway exit probably a little bit higher. So clearly that during the pathway propagation, slow pathway maybe was involved. So some of the conductions I went through the slow pathway, some of them did not. It looks like here. So if you look at the V pacing, it got a little bit longer, but not much longer, even the pacing septum. So I think this is just, look at that. Because rhetoric activation is exactly the same, almost. Okay. But if you look at your proximal A during the B pacing, his say much higher amplitude. Can you see that?
Yes.
Now pacing got smaller.
Yes.
But a vector polarity reversal is the same. What I mean, part of that went through the septum. That's what I mean. So I think his bundled EGM is very important. That's why you got to look carefully. So it's clearly B pacing is a fusion. This B pacing, then pathway. Okay. Yeah.
I think Dr. Rapali mentioned about potential epicardial pathway because the BL interval is pretty long compared to usual ABRT. Am I right?
Yeah. 156. Yep.
Yeah.
One pacing. Yep.
Where you ablate epicardial?
I know that's it.
Cardiac vein is epicardial, right?
All right.
Yeah. So in the usual, the MCV origin, the bypass tract has many branch to atrium, as Dr. Huang mentioned, sometimes to the both right atrium and left atrium. So it is good to ablate it from the MCV V insertion site is best. You can ablate by single bond, but that point is relatively dangerous area. Could you please comment about that?
Asking me or asking me?
Ask you.
Okay. MCV, there's a golden rule of MCV ablation. First of all, I saw you a bunch of that in there. So I hope you did not ablate the os of MCV. MCV is a vein with a relatively much thinner compared to coronary sinus muscular standpoint view. And all the days we used to ablate inside MCV invariably cause a significant stenosis. Fortunately, MCV stenosis really doesn't cause too much hemodynamic consequences. And then we don't worry about it. But there's a concern Dr. Park is mentioning. There's a posterolateral branch of right coronary artery cross right behind it. So all the days we did non-irrigation ablation, so it's a more resistive burn. So lesions was not deep enough to cause any trouble. These days, irrigation ablation, you're going to go through. Many patients have an asymptomatic stenosis of a posterolateral branch. So that's one of the reasons I said earlier. You map 3 sites first before you decide what to do. And we should do coronary sinus venogram as well. So you know exactly where you're mapping. That's what you're talking. So if I see coronary angiography and then MCV orientation too close, answer is no, you're not ablating there. So you have to chase, go to below the ventricle or above the different site. That would be first site of ablation. The very last, no other choice. You don't find any pathway potential except the MCV. Don't burn more than 3 times. You will get the stenosis. That's for sure. So a single burn, possibly if you can. Okay? That's why you need a bipolar, unipolar. Every tool you got, take a look, then you decide to ablate. But please, to differentiate fusion between septal activation and the pathway activation, you must put RV catheter right the posterior vessel septum pace from there. Then you map. That will maybe differentiate your pathway potential far better than septal pace. Okay, this is the message you can take home today. All right. Okay. So golden rule number, pathway, pace, closely insertion site, whether atrium ventricle doesn't matter. Move catheter. Okay. Then you constant pacing from there. You create a map, and then you guide the ablation. That will help you. Okay.
Morning, Dr. Huang.
Good morning.
Yes,
Who are you?
me. Hey,
Do I know
I'm
you?
good. Thank you so much.
Okay.
Yeah, I have one question to ask you.
Yes, please.
I guess.
Actually, last APHLS Young EP session, I also present about our subtotal bypass tract WPW patients, the one that we did during you come to Cambodia, and we also burn inside the MCV. One of
Yes.
the patients asked me that how can we make sure that it's safe using the non-irrigated catheter and ablation inside the MCV and without the contact force? So my answer is that it's based on the impedance. We can see the impedance. So if it's not dropped or it's not going too high, so it means that it's safe. But I'm not quite sure that the answer is still correct or not. So can you comment a little bit about this?
Okay. So first the rule is that you do venogram. Okay.
Yeah, we did that.
MCV size gotta be larger than your ablation tip. So not to occlude the flow.
Yeah.
Without program, you will not know. So if you occlude the vein, your impedance is gonna go sky high. That's what you're talking. Okay, right off.
Yeah.
You cannot burn. But that is not safe enough. So you really gotta see the physical dimension of MCV, and then also MCVs are sometimes very big. You need to know whether your pathway is a medial aspect of the MCV or lateral aspect of MCV or flow, so on. So you really have to map. It's not just the gold slam dunk thing. Okay? So you're going to have to find the biggest pathway potential, which site, and then you have a sharper signal, then that's what you're going to target. Now, we still believe if you're going to burn posterior to the MCV aspect, you better do angiogram, right corner angiography, to look at the posterolateral branch. Not safe.
Okay.
Okay? That is the answer.
Okay. So if during the ablation and the impedance is going high,
Yes.
so what should we do next? Change to the irrigation after?
I think first of all, posterior septal pathway probably most likely your irrigation is better than non-irrigation. The reason is if you do vein resistive burn, what happens with the vein? They kind of a straight stenosis quickly because of veins are not supported by the musculature. That's what we had experienced about early days of pulmonary vein stenosis because we burn inside the vein, pulmonary vein stenosis with the RF. So irrigation should be much better because it creates a deeper lesion, and then also irrigated so keep the tissue cool. So I think posterior septal pathways, right fourier pathways, all should be able to irrigation, most of them. Okay.
Okay.
Your technology.
And how about the power? So with non-irrigated, you start by how much, and then with irrigation catheter?
Irrigation catheter, you can start as low as 25 watts because of this pathway is you already, as the author mentioned, epicardial. It should be pretty close. So I think at 25 watts, it goes away. Then you watch impedance doesn't get higher. Then you can deliver maybe up to 30. But at most of 25, 30, you can get rid of those pathways. Okay.
Okay. And with non-irrigation?
Irrigated, not irrigated. I'm not sure there is about you can usually deliver 25 watts, 30 watts in non-irrigated. But then sometimes you cannot deliver higher than that because the flow is very limited, that area.
Yeah.
The impedance is going to go high. Okay?
Okay.
Yeah.
Okay. Thank you.
Dr. Han, I have a question for you.
Yeah, Professor Park.
Congratulations, you published the nodoventricular bypass tract paper with Dr. Huang and Melvin Scheinman. Congratulations again, and it is just accepted, right?
He's a publisher.
Yeah, just accepted. Thank you, Dr. Huang. Also, he helped us a lot during the manuscript review.
Okay, and coming back to this the Dr. Rafali's case. And do you think can we exclude the potential nodal ventricular bypass rate in this case?
Yeah, we can exclude nodal ventricular because we can see that during the PVC unhist, the A is at 1 also. So that means that atrium is involved, the part of the circuit. So probably, yeah, we can exclude the nodal ventricular pathway for this patient.
Okay, thank you.
Thank you so much, Professor Park.
Now, why you say that your ventricular extrasystole advanced A rule out the nodal ventricular? That doesn't show whether your atrium is independent of your tachycardia circuit. So you have to prove that your A can be disconnected from tachycardia circuit, right?
Yeah.
So you're delivering A extra, not the V extra.
Yep,
Now, when
yep.
this tracing, you can only say that if HV interval paradoxically gets shorter or longer, then that's suggestive of nodal ventricular. But it doesn't. It's stable. So that's why I asked the presenter earlier whether HV is stable, unstable. Post pacing.
Okay.
Okay?
Okay.
All right.
No more questions, comments? Okay, thank you. Dr.
Thanks so
Ashik,
much.
thank you
Okay,
for
thank you
sharing
very
such an
much for the
interesting case.
insightful feedback.
Okay.
Okay, hopefully you can involve more in the teachings. All right, thank you very much.
Thank
Have a
you.
great weekend. Thank you.
Okay.